Bismillahirrahmanirrahim. On to the fifth session of our abdominal unit, GIT unit. Basically, we are reading the first aid. So we are going to talk about the contribution of the external abdominal oblique muscle and the aponeurosis. So what is the contribution of the external oblique muscle? Out of all the muscular layers of the anterior abdominal wall, the external oblique muscle is the outermost layer. As you can see in this picture, not in this picture, in this session, they are saying that firstly we have the skin, then first we have the skin, then after the skin we have the superficial fascia. Just give me a second. Firstly there is skin, after the skin we have after the skin we have superficial fascia, that is divided into Kemper fascia and the Scarpa fascia. Then there is the external oblique muscle. We are right now talking about the external oblique muscle, that is lying immediately below the subcutaneous tissue or subcutaneous fascia. So here you can see the contribution of the external oblique muscle and the aponeurosis. In the inguinal ligament is the inferior rolled under aponeurotic fibers of the external oblique that extends between the anterior superior iliac spine and the pubic tubercle. So basically the inguinal ligament is the component or the part of the external oblique aponeurosis. It is the lower rolled margin that is extending from the anterior superior iliac spine to the pubic tubercle. Now here you can see in this picture that this particular thing, like the one I am highlighting right now, this thing is the inguinal ligament, and this inguinal ligament is extending from the anterior superior iliac spine that is present over here, anterior superior iliac spine, this thing, and all the way to the pubic tubercle over here. Like this is the pubis bone and this thing is called the pubic tubercle. So this thing that is extending from the anterior superior iliac spine all the way down to the pubic tubercle, that is called as that is referred to be as the inguinal ligament. First thing that you must remember. Then secondly, medially the fibers of the inguinal ligament form a flattened horizontal shelf called as a lacunar ligament. The flattened and horizontal shelf that is called as a lacunar ligament that attaches deeply to the pectineal line of the pubis and contains this pectineal line is the bony landmark. So the lacunar ligament is attaches deeply to the pectineal line of the pubis and continues as the pectineal ligament. The lacunar ligament forms the medial border of the femoral hernia. So if there is femoral hernia, the medial border is given by the lacunar ligament. So lacunar ligament, as you can see in this picture, this is the lacunar ligament where the deep fibers of the inguinal ligament are becoming continuous with the pectinate line of the pubis right down over here. This is the lacunar ligament, and then we have the other thing was pectinate ligament, right? That was that was pectinate ligament that attaches deeply to the pectineal line of the pubis and continues as the pectineal ligament. Okay. The lacunar ligament forms the medial border of the femoral hernia. We'll talk about the femoral hernia later on, but for right now remember these contributions of the external oblique aponeurosis. The first one was the inguinal ligament, second one is the lacunar ligament, and then there is a pectineal ligament. I guess I don't know, they have not depicted this pectineal ligament in this picture, but the pectineal ligament, as they have written over here, is the lacunar ligament. The pectineal ligament is the lacunar ligament that attaches deeply to the pectineal line of the pubis and continues as pectineal ligament. Okay, then so just remember that the lacunar ligament, both the lacunar and the pectineal ligament, both of them are arising, the lacunar ligament and the pectineal ligament, both of them are coming from the aponeurosis of the external oblique muscle. Superficial inguinal ring is a vertical triangular cleft in the external oblique aponeurosis. The superficial inguinal ring, it is very important because both the direct and indirect hernia will traverse this particular ring. When we do the hernias, I will tell you that it is the indirect hernia that is traversing two rings. That is indirect, that is the deep inguinal ring as well as the superficial inguinal ring. But when we talk about the direct hernia, that is herniating directly through the superficial inguinal ring only. It never enters the deep inguinal ring. But we'll see that in detail when we do the hernias. For right now, just remember that the superficial inguinal ring is a vertical triangular cleft in the external oblique aponeurosis that represents the medial opening of the inguinal canal just superior and lateral to the pubic tubercle. It is just superior and lateral to the pubic tubercle, as you can see in this picture. That that this opening over here, this triangular opening, like this thing, this opening is the superficial inguinal ring, and that is situated lateral and superior to that. Like it is superior and somewhat lateral to the pubic tubercle. So superior lateral to the pubic tubercle, we have a triangular opening. That opening is called as the superficial inguinal ring. It transmits the structure of the female and male inguinal canal in the physiologic the physiologic function of the superficial inguinal ring is to transmit the male and female reproductive organs. The male reproductive organs include the spermatic cord and the female reproductive organs, the female reproductive structures basically. The female reproductive structure that is present inside or that is traversing the superficial inguinal ring is the round ligament. You must also remember that the male testes, they also descend via superficial inguinal ligament downward into the scrotum through this inguinal canal and then exit through the superficial inguinal ligament to enter the scrotum. Now let's move forward to the next point, that is about the external spermatic fascia. So up till now we have seen that the inguinal ligament and its different divisions including the lacunar and the pectineal ligament, the superficial inguinal ring, and now the third component that is being given by the external oblique muscle is the external spermatic fascia. It is the outer layer of the three coverings of the spermatic cord formed at the superficial inguinal ring. So we will see that the spermatic cord has three layers and each layer is coming from each of the muscular layers. So the outermost covering is given by the external oblique aponeurosis, that is the external spermatic fascia is the outer layer of the three coverings of the spermatic cord formed at the superficial inguinal rings in the males. So here you can see this picture that we have seen these pictures, right? Okay, so this muscle is the external oblique muscle and this is the aponeurosis of external oblique muscle and the anterior superior iliac spine is present over there. If we could move downwards, so here they have depicted the inguinal ligament, like this thing is the inguinal ligament, then we have the femoral artery and vein as depicted like this. So this is the femoral artery and vein, the lacunar ligament is looking like this, and then we have the pubic tubercle. In this picture you can see a lot of different structures. There is the external oblique muscle, then we have the anterior superior iliac spine again, then the inguinal ligament is this thing. Then we have the femoral artery and vein, the spermatic cord is present over here, this is the spermatic cord. The superficial inguinal ring is the area from which the external spermatic cord is leaving the inguinal canal, like this opening is the external spermatic cord or external spermatic fascia, this opening is the superficial inguinal ring, and then we have the aponeurosis of external oblique muscle which is forming all of these structures. These structures like the inguinal ligament, the lacunar ligament, the superficial inguinal canal, everything is basically the thickenings and different openings in the external oblique muscle aponeurosis. So moving forward to the next point, the contributions of the internal oblique muscle. Firstly we have talked about the external oblique muscle, now we are going to talk about the internal oblique muscle. Internal abdominal oblique muscle and aponeurosis. Number one thing is conjoint tendon is formed by the combined arching fibers of the internal oblique and the transversus abdominis muscle. Conjoint tendon, it is very important tendon, it is formed by the combined arching fibers of the internal oblique and the transversus abdominis muscle. So there are two muscles which are contributing to the conjoint tendon. These are the internal oblique muscle, the second layer of muscle, and the transversus abdominis muscle, which is the third layer of the muscles that insert on the pubic tubercle, pubic crest posterior to the superficial inguinal ring. Okay, it forms and strengthens the medial wall of the posterior wall of inguinal canal. So it is going to strengthen the medial part of the posterior wall of the inguinal canal, and if the conjoint tendon is weak, there is an increased risk of herniations. Nerve supply is by the ilioinguinal nerve. The nerve supply of the conjoint tendon is coming from the ilioinguinal nerve. Remember that. The surgical importance, its weakness predisposed to direct inguinal hernia. If the conjoint tendon becomes weak, it will predispose to the development of direct inguinal hernia. Injury of the ilioinguinal nerve during the appendectomy will lead to the paralysis of the conjoint tendon, because we know that the conjoint tendon is being supplied by the ilioinguinal nerve. So ilioinguinal nerve, how to remember that? Because this is just below or the inguinal ligament somewhere, and just remember that it is being supplied by the ilioinguinal nerve. I don't know how to remember that, but the ilioinguinal nerve, it is supplying that, and if there is an injury to the ilioinguinal nerve, that injury to the ilioinguinal nerve will the injury to the ilioinguinal nerve will lead to maybe during appendectomy, like you were doing some sort of appendectomy and you damage the ilioinguinal nerve accidentally, and due to the damage of the ilioinguinal nerve, there will be paralysis of the conjoint tendon, and that will lead to the direct inguinal hernia, that is of the paralytic type. So there are different types of inguinal hernia, direct inguinal hernia, and the paralytic type is caused due to damage of the ilioinguinal nerve, and the ilioinguinal nerve, so the ilioinguinal nerve, the ilioinguinal nerve is supplying the conjoint tendon, and if it gets damaged, so what are we expecting? We will expect a direct inguinal hernia. Then we have it over here that the conjoint tendon prevents a direct inguinal hernia from descending to the scrotum, so its defect will lead to the direct descent of the direct inguinal hernia to the scrotum. It is very important. Normally the direct inguinal hernia never enters the scrotum. Normally, like in usual situations, if there is direct inguinal hernia, we don't expect the direct inguinal hernia content to enter the scrotum. But that is why is that so? Because the conjoint tendon does not let it go there. But if the conjoint tendon becomes weak, so the content of the direct inguinal hernia can leave the Hasselbalch triangle and enter into the scrotum. This is called as the funicular type. Okay, so there are in the paralytic type, there is damage to what? In the paralytic type of inguinal hernia, there is a damage to the ilioinguinal nerve, and then there is a funicular type in which the direct inguinal hernia is present inside the scrotum. The cremasteric muscle and fascia. Okay, so this is also coming from the internal oblique muscle, represents the middle layer of the spermatic fascia covering the spermatic cord and testes in the male. So cremasteric muscle and fascia, that is covering the middle layer of spermatic fascia. The external layer of the spermatic fascia was the external spermatic fascia coming from the aponeurosis of the external oblique muscle, right? The external spermatic fascia is the outer layer of the three coverings of the spermatic cord formed at the superficial inguinal ring, and that is coming from the external oblique muscle. From the internal oblique muscle, we have cremasteric muscle and its fascia, that is the middle layer of spermatic fascia covering the spermatic cord and testes in the male. Then the deep or internal inguinal ring. So the superficial inguinal ring was coming from the external oblique aponeurosis, and the deep or internal inguinal ring is coming from the internal oblique muscle. It is a small opening in the fascia transversalis immediately above the midpoint of the inguinal ligament and represents the lateral and deep opening of the inguinal canal. The inferior epigastric vessels and are medial to the deep ring. So suppose this is the deep inguinal ring, so the inferior epigastric vessels are lying medial to that. Okay, we'll see a mnemonic later on about the direct and inguinal hernia in reference to the inferior epigastric vessels. Then what is inguinal canal? It is a passage in the anterior abdominal wall extending from the internal inguinal ring to the external inguinal ring. So it is a canal. Okay, if it is a canal, so definitely it has two openings. It is a tunnel. One of the opening is called as the internal inguinal ring, and the other opening is called as the external inguinal ring. So it is internal inguinal ring, and then we have the external inguinal ring. So these two openings are going to form these two openings collectively constitute the inguinal canal. So now here you can see the deep ring is a hole in the transversalis fascia at the midpoint of the inguinal ligament, and here you can see the superficial ring is V-shaped. The superficial ring is not a ring, it is a V-shaped opening, V-shaped defect in the external oblique muscle. Sometimes it is called as a triangular opening. Then the contents of the inguinal canal in the males and females. In the male, the inguinal canal contains the spermatic cord and the ilioinguinal nerve. In the female, it contains the round ligament and the ilioinguinal nerve. The ilioinguinal nerve is common to both male and female. The difference is that in the males we have spermatic cord, and in the females we have the round ligament inside the inguinal canal. Moving forward, the ilioinguinal nerve in males, it supplies the skin of the lateral and anterior scrotum and the conjoint tendon. In the females, the skin of the anterior part of the mons pubis and the labia majora and conjoint tendons. The conjoint tendon is being supplied by the ilioinguinal nerve. Never forget this point. Then we have the triangle of Hasselbalch, that is also called as the inguinal triangle. It is a part of the posterior wall of the inguinal canal. It is bound. So the Hasselbalch triangle, I think they have given a picture of that. The Hasselbalch triangle is present. I guess this is the Hasselbalch triangle. Just give me a second. If there is a better picture of that. Hasselbalch triangle. This thing is a Hasselbalch triangle over here. This triangle, like this triangle, is a Hasselbalch triangle. So they have given the boundaries of Hasselbalch triangle. They are saying that it is bounded laterally by the inferior epigastric vessels, as you can see in this picture as well. Like the inferior epigastric vessels are forming the lateral wall of the Hasselbalch triangle. The lateral border of the rectus sheath. The lateral border of the rectus sheath is forming the medial border, and the inferior border is formed by the inguinal ligament only to the medial half. Only the medial half of the inguinal ligament. As you can see in this picture, that the lateral wall of the Hasselbalch triangle is formed by the epigastric vessels, the medial wall is formed by the rectus sheath, and the inferior wall is formed by the medial half of the inguinal ligament. So this forms the Hasselbalch triangle, and this triangle harbors the direct inguinal hernial contents. Now let's come back to this picture over here. The surgical importance. It is a triangle through which the direct inguinal hernia passes. Then we have this picture in which they have shown a lot of structures will move in an anti-clockwise fashion. So actually they are trying to depict the Hasselbalch triangle. The very first thing is the lateral most border, that is the inferior epigastric vessels, which are depicted like this. Both the arteries and the veins. Then the rectus abdominis muscle is like that. The inguinal triangle is present over here. This yellow structure. This thing is the inguinal triangle. Then we have superficial inguinal ring. The superficial inguinal ring is present over here. Then we have the lacunar ligament like this, as we have read before. Moving to the next point, this is the ductus deferens. So this is a male, now we know. Then the external spermatic, the external iliac vein is there. Then we have the external iliac artery. This is the vein, this is the artery. Then the testicular veins are coming out of that. Then we have the iliopubic tract, the anterior superior iliac spine, then the transversus abdominis muscle, and the deep inguinal ring is present over here. So, like this is the, if you know, let me see, just give me a second. So this is the left side of the patient, right? So this is the left half of the patient. There is the left side, and then we have the right side. So it is not, there is no right side in this picture because there is a medial section. So this is the left, these are the left structures, and this is the medial structure, this is the lateral structure. You may remember it like that. So now you can see that if you are talking about the Hasselbalch triangle, so they were saying that the lateral inferior epigastric vessels are formed in the Hasselbalch triangle. So in the Hasselbalch triangle, like this is the pubic tubercle, these are inferior epigastric vessels, so they are forming the lateral border of that and rectus abdominis muscle. So this is inguinal triangle. I guess the Hasselbalch triangle is also called as the inguinal triangle. Okay. So Hasselbalch triangle or the inguinal triangle is just one and the same thing. Now you can see that like these vessels are forming the lateral structure. The rectus abdominis muscle and its sheath are forming the medial wall, and the medial part of the inguinal ligament is forming the lower part of the base of it, inferior part. So this triangle is called as the inguinal triangle or the Hasselbalch triangle. Then we have facial layer of the spermatic cord. So there are three facial layers. The number one facial layer is the external spermatic fascia, as we have seen. It is formed by the aponeurosis of the external oblique and the superficial ring. The middle of cremasteric muscle. Just give me a second. Yep. So middle of cremasteric muscle and fascia are formed by the fibers of the internal oblique within the inguinal canal. The middle of cremasteric muscle fascia, the middle or the cremasteric muscle fascia, they are formed by the fibers of internal oblique within the inguinal canal, and the internal spermatic fascia is formed by the transversalis fascia at the deep inguinal ring. Okay. So all the three muscles are paying their contribution for the formation of spermatic cord. Yes. So external spermatic fascia from the external oblique muscle, the middle cremasteric muscle and fascia coming from the internal oblique, and the internal spermatic fascia from the transversalis fascia at the deep inguinal ring. So here you can see the clinical correlate in males. The cremasteric reflex can be demonstrated by lightly touching the skin in the upper thigh, resulting in a slight elevation of the testes. The sensory fibers of the reflex are carried by the L1 fibers of the ilioinguinal nerve, and the motor response is a function of the genital branch of the genitofemoral nerve that innervates the cremasteric muscle. So you must remember the names of these nerves. The sensory fibers are carried by the ilioinguinal nerves, and the motor component is coming via genitofemoral nerve. So ilioinguinal nerve is a sensory nerve, while the genitofemoral nerve is a motor nerve in the case of a cremasteric fascia, cremasteric reflex. When we are talking about the cremasteric muscle, when we are talking about the cremasteric reflex, okay, it will not get highlighted. So when we are talking about the cremasteric reflex, in the cremasteric reflex, the ilioinguinal nerve serves as a sensory component of the reflex, while the genitofemoral nerve, they will innervate the cremasteric muscle to give us the motor component of this reflex. Then moving forward to this point, like this is also a diagram, I guess from the first state, so we'll move in an anti-clockwise fashion again. So they have depicted the inguinal canal, the contents of inguinal canal, I guess in the male and female both. So here you can see like at different levels we have different layers of the spermatic cord or spermatic fascia. So if I just make it full screen so we can get a better view. So now here you can see, start from this point, like starting from here, we are starting from this thing downwards from the external fat, from the extraperitoneal fat. So from the extraperitoneal fat, we are starting from here. So you can see that the extraperitoneal fat is there. Then we have the transversalis fascia. After the transversalis fascia, we have the transverse abdominis muscle. The transverse, so the transversalis fascia is giving the. Then we have transversalis abdominis muscle. Then internal oblique muscle, external oblique muscle. I guess I should bring the pencil back. So here you can see that the extraperitoneal fat is the innermost layer. Then we have the transversalis fascia. The transversalis fascia is the fascia of the transversus abdominis muscle, which is the innermost muscular layer of the anterior abdominal wall. Here we have the transversus abdominis muscle. So remember that the fascia of the transversalis muscle is present below that or posterior to that, towards the viscera, on the visceral side, because the function of the transversalis fascia is to separate the transversus abdominis muscle from the peritoneum. So this fascia is present on the abdominal side. Then after the transversus abdominis muscle, we have the internal abdominal oblique muscle, then the external abdominal oblique muscle. So do you remember the components which are driven from all of these structures? From the transversus abdominis muscle, we have the internal spermatic fascia. From the internal oblique muscle, we have the middle cremasteric muscle of fascia, and from the external oblique, we have the external spermatic fascia. So here you can see the cremasteric muscle. It is coming from the internal oblique muscle, right? This is the cremasteric muscle as depicted here. Then after the cremasteric muscle, we have another point, that is the superficial inguinal ring. This is the superficial inguinal ring, and over here we have the deep inguinal ring. So the contents of the inguinal canal are traversing through the deep inguinal ring all the way up till the superficial inguinal ring, after which they exit the inguinal canal. Now here you can see that external oblique fascia and the external spermatic fascia. So external spermatic fascia is coming from the external oblique fascia. The internal oblique fascia will give the cremasteric muscle and fascia, and the transversus abdominis muscle or the transversalis fascia will give the internal spermatic fascia. Now moving on to this thing that is called as the conjoint tendon. It is very important tendon because it prevents the direct inguinal hernia to form, or if it is formed, it prevents the direct inguinal hernia to descend into the testis, right? So conjoint tendon or the falx inguinalis. Then we have the rectus abdominis muscle. After the rectus abdominis muscle, we have a weak area over here as well. For some reason, this area is weak. Then we have the inferior epigastric vessels, inferior epigastric arteries and vein. And you must remember this relationship, that the inferior epigastric vessels and veins are medial to the deep inguinal ring, or the deep inguinal ring is situated lateral to the inferior epigastric artery and the vein. Now moving on to the next point. The next point is present over here. This is about the hernias. Hernias are a protrusion of the peritoneum through the opening, usually at a site of weakness. So basically, protrusion is happening at a site of weakness. For example, an easy scenario to imagine: if there is a surgery, for example, a person underwent some sort of laparoscopic surgery, and now there is a scar, surgical scar present. Maybe there was a appendectomy. So there is a surgical scar of appendectomy on the anterior abdominal wall. Now that is the point where there was a cut. A cut was made over there, and after the cut, that point can lead to the herniation of the viscera from that point of weakness. So whenever I'm talking about hernia, you must imagine that there is some point of weakness through which the hernias are happening, or the hernias are taking place. Contents may be at risk of incarceration, not reducible back into the abdomen and pelvis, and strangulation, ischemia and necrosis. So incarceration means that they are fixed at a site in which they were herniated. Suppose this was the loop of the bowel, like this, and that herniated out to the external environment. Now it cannot be retrieved back. So this has been incarcerated over here, and suppose it came out and then the blood supply was lost, and this became strangulated over here. And if it is strangulated, so this area will become necrotic, and if this area becomes necrotic, like suppose we have a viscus that protruded out like this, now its blood supply is obstructed. If the blood supply is obstructed, so this area starts becoming necrotic, and there is a very limited palette. Let's use this color. So when this area becomes necrotic, just give me a second. It does not look necrotic. Let me use this color. Yep. So now you can see that this area is becoming cyanotic, and then later on it will become necrotic. So this necrosis and ischemia, that is termed as strangulation. So you have to differentiate between the ischemia, incarceration and strangulation. Nobody will ever ask you about differentiating between the strangulation and incarceration, but for general knowledge, you must know that incarceration is a hernia that cannot be reduced, and the strangulation is the ischemia and necrosis of a particular hernia. The complicated hernias can present with the tenderness, erythema and fever. If the hernias become complicated, they can present with the tenderness, the erythema and fever. Now here you can see the groin hernias. There are 3 or maybe 2 locations. So the indirect inguinal hernia is going to enter first into the deep inguinal ring, then it moves all the way to the superficial inguinal ring and comes out, and mostly it is present in the scrotum of the men, and I don't know the location of the females, we'll see that later on. But the indirect hernia enters the internal inguinal ring, right? The internal inguinal ring is traversed by the indirect inguinal hernia, while the direct inguinal hernia does not traverse the internal inguinal ring. So the indirect hernia is going to traverse the internal inguinal ring. Then we have this inguinal ligament. Then there is femoral artery and femoral vein. Do you remember the sequence of the femoral artery and femoral vein in the femoral triangle? It was navel, coming from lateral to medial direction. Firstly we get the femoral nerve, then there is femoral artery, then there is femoral vein, and then there is lymphatics. So venous near the penis, there was another mnemonic for that. Then we have this thing that we call the femoral hernia. The femoral hernia will come out through the femoral ring that is present over here. Like this is the femoral hernia. The femoral hernia is more common among the females. The direct inguinal hernia is coming out in the Hasselbalch triangle. The Hasselbalch triangle is formed by the inferior epigastric vessels on the lateral aspect, the rectus abdominis sheath on the medial aspect, and the medial half of the inguinal ligament on the lower aspect of the Hasselbalch triangle. So that harbors the direct inguinal hernia. And after the direct inguinal hernia, we have the inferior epigastric vessels over here, and the rectus abdominis muscle is like this. Now let's talk about this. So here you can see the groin hernia, the indirect inguinal hernia. The classic presentation is a male infant. Pathophysiology is the patent processus vaginalis. The processus vaginalis is basically the structure that directs the testis from the abdomen through the inguinal canal into the scrotum, and this is the protrusion of the peritoneum, and it normally obliterates in the adult people, and if it does not obliterates, this can give room to the inguinal viscera to protrude into the scrotum. So the pathophysiology of the indirect inguinal hernia is the patent processus vaginalis. Anatomy: the contents protrude through the deep inguinal ring. Remember this thing, internal inguinal ring or the deep inguinal ring, and then it travels through the lateral to the inferior epigastric vessels, because the deep inguinal ring is present lateral to the inguinal vessel, as we have seen in this picture, like this thing. The deep inguinal ring is situated lateral to the inferior epigastric vessels. So is the indirect hernia. So indirect hernia is situated lateral to the inferior epigastric vessel. We will see a mnemonic of that later on. Then we have the direct inguinal hernia that is seen in the older men. Remember, the indirect inguinal hernia is seen mostly in the male infants, while the direct inguinal hernia is seen in the older men. The pathophysiology is a weakness of the transversalis fascia. Then we have the contents. The direct inguinal hernia, the pathophysiology is a weakness of the transversalis fascia. The contents protrude through the Hasselbalch triangle. They travel to the inferior epigastric vessels. They travel medial to the inferior epigastric vessels. So the Hasselbalch triangle, if you remember the anatomy of the Hasselbalch triangle, we saw that the inferior epigastric vessels are making the lateral wall of that, right? And the medial wall is formed by the rectus abdominis sheath. So since the inferior epigastric vessels are forming the lateral wall, so whatever structure is present over here, that is definitely medial to the inferior epigastric vessels. So just try to make the anatomy very clear in your mind so that you could remember these points, and then we'll go to a mnemonic as well. So the direct inguinal hernias are present medial to the inferior epigastric vessels, while the indirect inguinal hernias are present lateral to the inferior epigastric vessels. Now the femoral hernia, they are present more commonly in the women. The weakness of the proximal femoral canal, there is a weakness of the proximal femoral canal, and the contents protrude through the femoral ring, and they travel inferior to the inguinal ligament. Now you can see this is the diaphragmatic hernia. We have talked about diaphragmatic hernia, I guess, before, but this hernia is also called as the box-the-leg hernia. Okay, so since we are talking about hernia, so why not diaphragmatic hernia as well? So in the diaphragmatic hernia, there is an opening on the left side of the diaphragm. Why left side? Because on the right side there is somewhat protection by the liver, right? On the right side we have a relative protection coming from the liver. So mostly the box-the-leg hernia is due to the opening on the left side, and through this left sided opening in the diaphragm, the intestinal viscera can move upward, and this whole process is happening during the intrauterine life. So what happens is that small intestine in the left chest pushing the heart and lungs to the right side. In this picture you can see that this lung on the left, this left lung and the heart, these are pushed to the right side, and the viscera are occupying the space in the thoracic cavity which was reserved for the left lung and the heart. The liver is partially up into the chest. Okay, so this is a very severe kind of box-the-leg or a diaphragmatic hernia in which the liver is also protruding into the left side chest, and then this is the diaphragmatic hernia. So basically the thing is that suppose, okay, let's draw it here. Like suppose that we have a place like these are the lungs, this one is the right lung, and here we have the left lung, below them we have the diaphragm, and under them we have these intestines. there is some relative protection by the liver. So the stuff is like that. If there is some sort of opening or some sort of defect present in the, if there is some sort of defect that is present on the left side of the diaphragm, like over here, so this will allow these intestines to enter all the way up into the left cavity. So when the content of the intestine are entering into the left cavity, the left lung will become hypoplastic, it will become very small, and in place of this lung there will be viscera, and maybe that this lung is pushed to the right side along with, it is also possible that this lung, this is pushed to the right side, along with that maybe the heart is also pushed to the right side, and the whole left hemithorax is occupied by the intestine. When this lung is not developed, the child, after the infant, when he or she is born, he is in severe respiratory distress because this lung is not contributing to the oxygenation of the blood, and that hypoxemia can result in the fetal demise. We'll see all of these details later on in the respiratory unit. For right now, just remember the diaphragmatic hernia and pathophysiology as I have explained over here. Then we have abdominal structures enter the thorax may occur due to the congenital defect in the pleuroperitoneal membrane. Okay, so there is a pleuroperitoneal membrane. It is a embryonic form of the diaphragm, right? In place of diaphragm in an embryo, we have the pleuroperitoneal membrane, and that pleuroperitoneal membrane in future will become the diaphragm. So if there is a defect in the pleuroperitoneal membrane, or as a result of the trauma, so there is abdominal structures, they will start entering the thorax. Commonly occurs on the left side due to relative protection of the right hemidiaphragm by the liver. Most commonly a hiatal hernia in which stomach herniates upward through the esophageal hiatus to the diaphragm. Okay, most common form of hernia is the hiatal hernia. It is not related to the diaphragmatic hernia, it is another topic. It is a different topic. So hiatal hernia is seen even in the adults, even in the healthy adults. The hiatal hernia is a condition in which the stomach herniates upward through the esophageal hiatus into the diaphragm. We know that the esophageal hiatus is present at the level of T8. Suppose this is the diaphragm, and here we have the opening, and through this opening the esophagus is entering downwards, and it is becoming stomach like this, right? It is forming a stomach like this and this. If this stomach starts herniating upwards, like I am drawing it over here, like if it looks something like this, that the stomach cardia is present over here and something like this, so this is called a sliding hiatal hernia. Or maybe in another situation, maybe the stomach has protruded out like this, it is called as a paraesophageal hiatal hernia. So in both these situations, the stomach is coming out of the physiological opening that is present for the traversing of the esophagus through the diaphragm or the esophageal hiatus of the diaphragm. Now moving to the next point. Okay, so in this picture you can see that this is the umbilical venous line. The heart is present on the right side, and the bowel is present on the left hemithorax, and then the nasogastric tube that is passing down into the stomach maybe or something, I don't know. Then we have this thing that is called as a sliding hiatal hernia. The sliding hiatal hernia is depicted very beautifully in this diagram. So the sliding hiatal hernia is most common. It is gastroesophageal dysfunction. Gastroesophageal junction is displaced upward, and we get an hourglass appearance. Hourglass, if you have seen some historic cartoons, so there used to be a sand hourglass looking like this, and there were sand granules present over here. They were dripping down like this, and the sand accumulates like this. So this was called an hourglass, and this hourglass appearance is seen in the hiatal hernia. So this is in the sliding hiatal hernia. And then we have the second thing, the sliding hiatal hernia. This is the picture of that. And then we have the paraesophageal hiatal hernia. In the paraesophageal hiatal hernia, gastroesophageal junction is usually normal. The fundus protrudes into the thorax. So it is a fundus that is protruding into the thorax. In the case of sliding hiatal hernia, the cardia extends upward. And in the case of paraesophageal hiatal hernia, the fundus of the stomach that becomes parallel to the esophagus, while the gastroesophageal junction, like you can see the gastroesophageal junction, lower esophageal sphincter or the gastroesophageal junction that is present over here, it is in its place. When we talk about sliding hiatal hernia, the gastroesophageal junction has been displaced all the way up into the esophagus. The next point is about the descent of testes. So when we talk about the descent of testes, you must know that testes are basically abdominal organs. They are formed or developed in the abdomen, and then they descend downwards. So these are the testes, and this is the peritoneum. The testes under the direction of the processus vaginalis, as you can see over here. This is processus vaginalis, and this is the gubernaculum. The processus vaginalis and the gubernaculum is directing the testes downwards, and then you can see over here. I'm really sorry for the noise. So the processus vaginalis and the gubernaculum, they are directing the testis all the way down into the testis, and then the processus vaginalis becomes the tunica vaginalis after the obliteration of the processus vaginalis, and the gubernaculum, that is incorporated into the testis as I don't know, maybe as tunica albuginea or something, I don't remember like that, but even the gubernaculum is going to get incorporated into the testis. So this is a normal descent of the testis. The testis develop in the mesoderm. From the mesoderm, the testis develop from the mesoderm of the urogenital ridge within the extraperitoneal connective tissue. During the last trimester, the testis descends the posterior abdominal wall inferiorly towards the deep inguinal ring, guided by the fibrous gubernaculum into the inguinal canal through the deep inguinal ring. Then through the superficial inguinal ring, they come into the testis. They come into the scrotum. An evagination of the parietal peritoneum and the peritoneal cavity extends into the inguinal canal called as a processus vaginalis. So there is an evagination. So there is an evagination of the parietal peritoneum and the peritoneal cavity extended into the inguinal canal, that is called as the processus vaginalis. Moving forward, we have the open connection of the processus vaginalis with the peritoneal cavity closes before birth. The open connection between the peritoneal cavity, processus vaginalis, and the peritoneal cavity that closes before birth. A portion of the processus vaginalis remains patent in the scrotum and surrounds the testis at the tunica vaginalis. The persistent processus vaginalis, if the processus vaginalis is persistent, the persistent processus vaginalis often result in a congenital indirect inguinal hernia. Now let's talk about the indirect inguinal hernia. Indirect inguinal hernia goes through the internal inguinal ring. Remember, the in the indirect inguinal hernia is for the internal or the deep inguinal ring. The external inguinal ring, so both of these rings are covered by the indirect inguinal hernia and into the scrotum. It enters the internal inguinal ring lateral to the inferior epigastric vessel. So there is a mnemonic, I guess they have written it somewhere, but the mnemonic is MDs don't lie. May you all become MDs one day. So the direct inguinal hernia traverse medial to the inferior epigastric vessels, while the indirect inguinal hernia, they traverse lateral to the inferior epigastric vessel. So MD is medial ones are the direct, and the lie means lateral ones are the indirect. So let me remove this one and then we'll go back to our discussion. Coming back to the discussion, now you can see that the external inguinal ring lateral to the inferior epigastric vessel, so they descend lateral to the inferior epigastric vessel, then occurs in the infants owing to the failure of the processus vaginalis to close. They can form hydrocele, much more common in the males. For some reason, the hydrocele formation or the indirect inguinal hernia is much more common in the males, and indirect inguinal hernia follows the path of descent of the testis. It is covered by all the three spermatic fascia. All the three layers of spermatic fascia are covering the indirect inguinal hernia. Moving forward, we have the normal anatomy. So in this normal anatomy, if I could zoom it in, so you can see that there is obliterated processus vaginalis like this, and the spermatic cord is present over here, and this is the tunica vaginalis coming from the obliterated processus vaginalis. The tunica vaginalis cavity is also present. Then the gubernaculum is the attachment. Here you can see that the gubernaculum is helping the is attaching the scrotum to the floor of the is attaching the testis to the floor of scrotum. This is the gubernaculum, then here is the scrotum. After that we have the patent processus vaginalis is present over here. If the processus vaginalis is patent, the inguinal roof can descend downwards through that patent processus vaginalis. So here you can see the small intestines and stuff like that. In this picture you can see the normal anatomy, like the spermatic cord, and this is the inguinal canal with a deep inguinal ring and the superficial inguinal ring. This spermatic cord, testis, normal anatomy, and the inguinal hernia loop of intestine is traversing through the inguinal canal from the deep inguinal ring to the superficial inguinal ring and into the spermatic cord, and into the testes and stuff like that. Now moving forward to the next point, that is direct inguinal hernia. The direct inguinal hernia protrudes through the inguinal or the Hasselbalch triangle. You must remember this thing. It is very high yield point that the direct inguinal hernia is protruding through the inguinal or the Hasselbalch triangle. It bulges directly through the abdominal wall, medial to the inferior epigastric vessels. It goes through the external superficial inguinal ring only. So direct inguinal hernia is traversing only the superficial inguinal ring. It is covered by the external spermatic fascia. So the indirect inguinal hernia was covered by all three layers of spermatic fascia. You must never forget this point, that the indirect inguinal hernia is covered by all three layers of spermatic fascia. While if I am talking about the Direct inguinal hernia, it is covered only by the external spermatic fascia because it is traversing only the external or superficial inguinal canal. It is traversing only the superficial inguinal ring. So it is covered by the external spermatic fascia, usually in the older men. So there is a mnemonic that is MDs don't lie. Medial to the inferior epigastric vessel is the direct hernia, and lateral to the inferior epigastric vessel is the indirect inguinal hernia. Then in this picture you can see the intestine pushing through the peritoneum. Superficial inguinal ring is present over here, and if this content is traversing only the superficial inguinal ring, this is the spermatic cord. So this is the direct inguinal hernia that is present in the Hasselbalch triangle and traversing only the superficial inguinal ring. Then we have another hernia that is called the deep another type of hernia that is called as the this type of hernia is called the indirect inguinal hernia, and this indirect inguinal hernia is traversing both the layers, superficial as well as the deep inguinal ring. Just give me a second. Yeah, so now you can see that the deep inguinal ring is present over here. The intestinal loop has traversed that, enter the inguinal canal, then it is exiting through the external or superficial inguinal ring, and this kind of hernia is covered by all the three layers, as you can see in this picture. Like this is intestine within the spermatic cord, so this is covered by all the three layers of spermatic cord or spermatic fascia. Then we have in this picture, you can see the inguinal or the Popart ligament. The indirect inguinal hernia is originating at this point from the deep inguinal ring. There is the femoral artery, then we have the femoral vein. The femoral hernia is present in the femoral ring below the inguinal ligament. Remember, the direct and indirect inguinal hernia, they are present above the inguinal ligament, while the femoral hernias are present below the inguinal ligament. Then we have the Hasselbalch triangle. So direct inguinal hernia is present in the Hasselbalch triangle, like this small thing. If I could zoom it in, so now you can see it better. There is a triangle. They have formed a triangle over here, like this, this, and this. So this triangle is formed by three things. On the lateral wall, that is formed by the inferior epigastric vessel, the medial wall is formed by the rectus abdominis muscle sheath, and the lower border is formed by the inguinal ligament. Then we have the direct inguinal hernia is coming in the Hasselbalch triangle. The inferior epigastric vessels are forming the lateral wall, and the rectus abdominis muscle is forming the medial wall, and this is harboring the direct inguinal hernia inside it. Then moving forward, this is the again a schematic diagram of what type of hernia. I guess they are depicting direct inguinal hernia. So they are saying that yes, this is direct inguinal hernia. Okay, they have not labeled the diagram. So here you can see that this is the parietal peritoneum, and the conjoint tendon is present over here. Then we have the peritoneal bulge, which can be formed if there is direct inguinal hernia. Then there is superficial inguinal ring that is present over here. The testes are like over here, and then we have the inferior epigastric vessels. The deep inguinal ring is over here, and the external extraperitoneal fascia is over here. So this is the medial direction, this is the lateral direction. If the direct inguinal hernia is being formed, it will come in this direction, and then it will traverse through the superficial inguinal ring to enter the Hasselbalch triangle, and that is situated medial to the epigastric vessel. If I am talking about the indirect inguinal hernia, so it will enter the deep inguinal ring that is present lateral to the inferior epigastric vessel. So this is how the things are working. Then we will move forward to the next point, that is about the femoral hernia. Femoral hernia is common type of hernia in the females, but even then, remember, it is not the most common type of hernia in the females. The most common overall hernia, either in males or females, is the indirect inguinal hernia. The femoral hernia protrudes below the inguinal ligament through the femoral canal, below and lateral to the pubic tubercle. It is more common among the females and more likely to present with the incarceration and strangulation than the inguinal hernias. So incarceration and strangulation is more commonly seen with the femoral hernias. Now in this picture you can see the femoral inguinal hernia. I guess the sake of the indirect, all type of hernias are submitted in this picture. So they have shown the inguinal ligament, like this purple thing, like this thing. This is the inguinal ligament, and in the inguinal ligament, if you could see, these vessels are the inferior epigastric vessels, and there we have the internal inguinal ring. This is the external inguinal ring, and coming out of the external inguinal ring, we have the sac of indirect hernia, which started in the indirect inguinal ring and stuff like that. This is the pubic tubercle. Below the inguinal ligament, we have the sac of femoral hernia. In the femoral triangle, we have three things, which are the nerve, artery, and vein. Coming from lateral to the medial direction, we have the nerve, then we have artery, and then we have the vein, and there is a muscle. There is a muscle that is called the iliacus muscle. Moving forward to the vessels of the anterior abdominal wall. So the vessels of anterior abdominal wall are depicted very beautifully in this picture. Will come again in a counterclockwise fashion. These are not the vessels of anterior abdominal wall per se, like we are talking about the axillary vessels, so they are present in the thorax, they are present in the axilla basically. Then we have the long thoracic vessel that is present on the anterior aspect of the chest. Both veins and arteries are present. Then the thoracoepigastric vessel, or the vein you may say that. Then we have the rectus abdominis muscle. The umbilicus is present over here, like this is the umbilicus. And then we have the external oblique muscle. Okay. The superficial epigastric vessels are present over here. Where is rectus abdominis muscle? That is rectus abdominis, and these are vessels. Then superficial circumflex iliac vessels are present over here. Then we have the femoral vessels. After the femoral vessels, you can see over here the deep external pudendal vessels. Okay, these are supplying the genitalia and the rectum. The superficial external pudendal vessels are present over here. The transversalis fascia, and traversing the transversalis fascia, we have the inferior epigastric vessels. The arcuate line is like this, and then we have the transversalis abdominis muscle, the internal oblique muscle, and the superficial epigastric vessel, and this is the whole diagram in one go. Moving to the next point, that is umbilical hernias. So, uncomplicated umbilical hernia. Umbilical hernia is basically a hernia in which the problem is that umbilical ring is not completely closed. Suppose this is the umbilical ring, it is supposed to be closed soon after the herniated content. You know that in the in the 6th week of gestation, the content from the gut that protrudes outward from the mid gut protrudes outward through the umbilicus into the amniotic cavity, right? And then it gets itself rotated to 270 degrees, and then it is reduced back into the abdominal cavity, and the umbilical ring constricts after that. If the umbilical ring fails to constrict properly, so there will be umbilical hernias. And if we are talking about the uncomplicated umbilical hernias, the pathology is that there is a defect in the linea alba covered by skin. The clinical features are reducible bulge at the umbilicus, notably with the increased abdominal pressure, for example when the child is crying or maybe passing the bowel movements. So uncomplicated umbilical hernias are basically seen in the children. Associated conditions are the Down syndrome. You must never forget any association of the Down syndrome, because it is a very high yield concept and they often test you on this thing. Then we have hypothyroidism and the Beckwith-Wiedemann syndrome. Normally, the umbilical ring or the congenital facial opening of the umbilicus forms the linea alba. Normally, the umbilical ring or the congenital facial openings form the umbilical cord, closes and forms the linea alba, a midline band of the fibrous tissue. The umbilical hernias are caused by an incomplete closure of the umbilical ring, therefore allowing the protrusion of the bowel through the abdominal musculature. Most umbilical hernias are reducible, asymptomatic, and resolve spontaneously in the first few years of life. They can occur in isolation or in association with other conditions such as Down syndrome. And you must remember that these are the femoral hernias in which we have an increased chance of strangulation and incarceration. Then what is appendicitis? It is one of the most common problems which you often see in the surgical emergencies of your hospitals. So the dull visceral pain at the umbilicus due to the afferent pain fibers entering the T10 level of the spinal cord. If I could draw an abdomen over here, so it looks something like this, and then like this and this. So if I divide this into 9 quadrants, so the uppermost quadrant is the epigastrium, then we have the umbilical quadrant, and then we have the hypogastrium, right? So the pain from the foregut is referred to the epigastrium or the epigastric region. The pain from the midgut will go to the umbilical region, and the pain from the hindgut will go to the hypogastric region, right? So now let's come back over here. That the appendicitis, there is dull visceral pain at the umbilicus due to the afferent pain fibers entering at the T10 level in the spinal cord. The progressive inflammation in the appendix irritates the parietal peritoneum. The progressive inflammation in the appendix will irritate the parietal peritoneum and abdominal wall to cause more severe somatic pain, shifting from the umbilicus to the McBurney point. So initially we have pain in the umbilical region, like initial pain is in the umbilical region, and later on it refers somewhere else. Like initially it is in the umbilical region, but later on when the inflammation is large enough, and whenever the inflammation increases, when the inflammation is increased, the parietal peritoneum gets stretched. The parietal peritoneum and the abdominal wall cause more severe somatic pain, shifting from the umbilicus to the McBurney point, that is 2/3 the distance from the umbilicus to the anterior superior iliac spine. We will see the McBurney point later on when we do the appendicitis. But right now remember that initially the pain is felt, there is a dull visceral pain in the umbilicus that shifts from the umbilicus to the McBurney point, that is 2/3 the distance from the umbilicus to the anterior superior iliac spine. If you draw an imaginary line starting from the umbilicus to the anterior superior iliac spine, starting from the umbilicus moving 2/3 the distance toward the anterior superior iliac spine, we get the McBurney point, which is the point of secondary pain, you may say that, in the case of not the secondary pain but the pain in the uh, later cases of the the appendicitis. Then what is Kehr sign? Kehr sign is the referred shoulder pain due to the peritoneal irritation. Rigid abdomen and left shoulder pain will be felt, and left shoulder pain, so we are expecting that to be occurring in the case of maybe splenomegaly or something. The patient present with the right abdomen with associated left shoulder pain. Hypotension, tachycardia suggests a possible splenic laceration and hemoperitoneum. It is rigid peritoneum. Okay, so if the patient comes to you with a rigid peritoneum associated with a left shoulder pain, hypotension, tachycardia suggest a possible splenic laceration and the hemoperitoneum, the shoulder pain likely represents the referred pain due to the peritoneal irritation, that is called as a Kehr sign. The phrenic nerve originates from C3 to C5 and pass between the lung and heart to provide the motor function to the diaphragm. So since we know that the phrenic nerve, the root values for phrenic nerve are C3, C4 and C5, and when they get irritated, the pain is referred to the shoulder. So they pass between the lung and the heart to provide the motor innervation to the diaphragm, and this is how it is happening. The phrenic nerve also, okay, so let's complete it. The phrenic nerve also provides the sensory fibers to the pericardium, the mediastinal pleura and the diaphragmatic peritoneum. The supraclavicular nerves also originate from the C3 to C4 levels, and their branches innervate the sternoclavicular joint, the local muscle, for example the sternocleidomastoid, and the skin of the upper and the posterior shoulder. Any abdominal process, for example the ruptured spleen, the peritonitis, or maybe the hemoperitoneum irritating the sensory fibers around the diaphragm can cause referred pain by the phrenic nerve to the C3 to C5 shoulder region. The phrenic nerve irritation can also cause hiccups due to the spasmodic diaphragmatic contraction pulling the air against a closed larynx. So the hiccups are basically happening because of the irritation to the phrenic nerve. The left upper quadrant pain with the left shoulder pain, that is Kehr sign, with the nausea and vomiting and a history of embolic disorders, that will lead to splenic infarction. Now that is going to take us to the diagnosis of splenic infarction. Like if a person presents to you with the left upper quadrant pain and left shoulder pain, that is Kehr sign, with the nausea and vomiting and a history of embolic disorders, so you must suspect splenic infarction, right? So we'll keep this session till here. Until next time, Allah Hafiz, fi amanillah, and take care.